presentations. This is Vivian, the Gaspin president. I would like to continue our accredited program with our next speaker, Melissa Bailey. Melissa's experience lies in acute care inpatient and outpatient adult nutrition with a focus on thoracic surgery, surgical oncology, solid transplantations, and the surgical ICU. She is currently the clinical nutrition manager of K-Farm. Let's welcome Melissa Bailey.
Thank you so much, Vivian. Thank you for having me today. It's an honor to be here with you all. So we are going to talk about the history and benefits of plant-based nutrition. We're going to go into a brief introduction, talk about the background of plant-based diets, some possible mechanisms, just plant-based diets in general, and how this relates to plant-based formulas, disease-specific applications, and then wrap up with a conclusion. I will mention, for those of you following along with the slides, in order to meet the 30 minutes that we have today, I did reduce some of the slides in this presentation, but you have all of the information for you for any additional details you might need.
I was trying to get them like this.
So starting off with plant-based, what exactly does plant-based mean? Well, interestingly, there's no consensus definition right now on the term plant-based, but we know that, consumers and patients are following, various ranges of a vegetarian or vegan diet. And so we go from one end of the spectrum where we have patients who are vegan and following where they're not eating any animal products or byproducts. Then maybe those who are ovo-lacto-vegetarian and incorporating either eggs or some parts of dairy. Pescatarians who may be adding in fish, but mostly eating a lot of fruits, vegetables, and grains. And of course, all the way up through omnivores who are eating animal-based products. And so interestingly, when we look at this, the term plant-based really is focusing on that whole food ingredient. So there are vegan products that are not necessarily plant-based because they are very highly processed. We also know that when planned appropriately, vegan and vegetarian diets can be nutritionally adequate. Looking at a brief history, vegetarian and vegan diets have actually been around for many centuries, dating back as far as 500 BC. You can see here historical figures such as Pythagoras, Leonardo da Vinci, and Benjamin Franklin were reportedly vegetarians. And then moving into the 1800s, Seventh-day Adventists often followed a vegetarian or vegan diet. And then when you look at today, about 4 years ago in 2016, there was a poll that showed about 3.3% of Americans identify as vegetarian or vegan, mostly within the age range of 18 to 44 years old. And interestingly, the most concentrated regions are the Northeast and the West Coast. That's where you find the highest amount of vegetarians or vegans. There are other benefits to a plant-based diet besides just the health benefits. So this is environmentally friendly. We know that the production of plant-based proteins and plants in general reduce greenhouse gas emissions. We also know there's a lower water requirement to produce plant protein compared to animal-based proteins. It's more sustainable, requires a lot less land, and also less phosphorus mining. Economically, it has been shown to reduce global mortality rates with an estimated savings of anywhere from $1 to $31 trillion saved. So it goes just beyond the health benefits. There's a lot of economic benefits as well too. And we do find that when we ask, consumers, why are they following either a vegetarian or a vegan diet? It's not always just about eliminating animal products. For that reason, it could be about the economic benefits as well too. Looking at the health benefits of a plant-based diet, we know that it's been shown to reduce disease risk and mortality, help to prevent chronic disease. It can aid in desirable weight loss, and we know that that can be helpful with many different disease states. Lower cholesterol levels, it can improve glycemic control and insulin resistance, lower blood pressure, and decrease markers of inflammation. It's also been shown to lower risk of certain cancers, type 2 diabetes, and overall mortality. Looking at some health statistics, right? We are looking here at cardiovascular disease, cancer, diabetes. So cardiovascular disease, the #1 leading cause of death in the US. Annual estimated cost of care is about $351 billion. That's as of last year. Cancer is the #2 leading cause of death here in the US with an estimated average of $147 billion in costs. And diabetes, about 10.5% of the population in the US is diagnosed with diabetes. And interestingly, 95% of those are diagnosed with type 2 diabetes, which we know can either be prevented or even treated with diet modifications. Annual cost for care of diabetic patients was $327 billion in 2017. So then you look at some of the risk factors for these disease states that are listed here, things like hypertension, obesity, high cholesterol, and then of course pre-existing diabetes as well. And we look at the prevalence of these in our population, and we know that these are all modifiable risk factors, and that plant-based diets may help to lower some of these risk factors in our patients. Again, looking at the overall health benefit here, we know that plant-based diets are including lots of fruits and vegetables, whole grains, seeds, and nuts. And you can see here that overall, vegetarians have a 12% lower all-cause mortality rate, 22% lower risk of colorectal cancer, 35% lower risk of prostate cancer, and they are 74% less likely to develop diabetes. So we can see the benefits here, and a lot of these have been done in long-term studies. Looking at some more studies that have been done over a pretty long period of time. So the first one was a systematic review of 8 prospective studies among the Seventh-day Adventists following vegetarian diets. They showed that they had a 40% reduced risk of coronary heart disease and 29% reduced cerebral vascular disease events compared to non-vegetarians. The study that's listed on the right-hand side was a European prospective investigation, otherwise known as the EPIC study. This was done in 10 European countries for almost 15 years. It followed a very large cohort of patients and found that over that period of time, there was a 32% lower risk of developing coronary heart disease compared with non-vegetarians. We also know that plant-based diets appear to reduce the risk of developing metabolic syndrome by about 1/2. Things that it really feeds into is decreasing waist circumference, decreasing serum triglycerides, total and LDL cholesterol, as well as blood sugar. So by reducing the risk of these individual components of metabolic syndrome, then overall we're able to reduce the risk of developing metabolic syndrome. So what are some of the mechanisms that may play a part in a plant-based diet? We know that these diets are rich in fiber. Fibers can be lipid lowering. We also know that prebiotic fiber is fermented in the colon, and it can help to maintain intestinal health. We know that this is great for our gut microbiome, and we know that there's a lot of research right now on our microbiome and how that plays into our overall health. Fiber can also help to normalize bowel movements by improving consistency, and this can reduce the risk for diverticular disease. Certain fibers are slowing the absorption of carbohydrates, which therefore can improve blood glucose levels. And also fiber can help to achieve a healthy weight since it helps with satiety. So we know that when we eat these fiber-rich foods, right, we feel fuller, we feel satiated for a lot longer. And also when we're eating a lot of these plant-based foods, we're lowering animal products which contain cholesterol and are pretty high in saturated fat. They also contain phytonutrients, which is another health benefit of all of these plant-based foods. So the American Institute for Cancer Research recommends that individuals increase consumption of fruit and vegetables in their diet. What are phytonutrients? So they are bioactive substances that are found in plant foods only. They are not found in animal foods. They are not nutrient-based, so they don't provide any protein, carbs, fats, vitamins, or minerals. However, they do give their plants their color, flavor, and odor. So actually, if plants were missing phytonutrients, they would have a lot less color, a lot less aroma and flavor as we know it. Phytonutrients, as well as some vitamins and minerals, can act as antioxidants to scavenge free radicals. So for patients that are consuming a largely plant-based diet, they're getting this benefit of the phytonutrients that they may not be getting as much if they were consuming more of an animal-based diet. These are some examples of phytonutrients, and we can find them in all sorts of food sources, again, on the plant-based side. So lycopene and carotenoids, we know we find those in things such as tomatoes, carrots. You have things like resveratrol, which you can find in grapes or red wine. You can have catechins, which are often found in black and green tea or other types of teas. Also, we know that coffee and chocolate can be rich in these phytonutrients and antioxidants as well. And this really is just the tip of the iceberg. There's only so many phytonutrients that are well known and studied right now, but there are actually believed to be thousands of phytonutrients that exist and really just have not been explored yet in the data. What are some of the impacts of phytonutrient consumption? They do play an important role in our overall health. So they may help in the prevention of things such as aging, diabetes, cancer, heart disease, so prevention of disease overall. They may also function as antioxidants, provide antibacterial benefits, or be anti-inflammatory, as well as many other roles. Getting into some of the clinical data. So we're going to go through a few studies here that really are looking at plant-based and vegan diets. So here in this study, this was a low-fat vegan diet and a conventional diabetic diet were assessed over 74 weeks. The control group followed the 2003 ADA guidelines and a prescribed energy deficit. The treatment group followed a vegan diet that excluded all animal products and high-fat foods, including anything fried, avocados, nuts, and seeds. And energy intake was ad libitum. Each participant met with an RD and was able to establish appropriate diet plans for them. Participants met weekly for 1-hour meetings for the first 22 weeks and then bi-weekly thereafter in their groups. And so in this, it showed that both diets, so the vegan diet or the diabetic diet, resulted in weight reduction. The vegan group had a larger amount of weight loss compared to the control group. The vegans also had a greater decrease in their overall A1C levels. And then total and LDL cholesterols were reduced among both groups. However, it was a greater reduction found in the vegan group. So both dietary modifications really did play a part in improving, these health outcomes, but the vegan diet showed some greater benefits here. Another trial was a multi-center randomized control trial of a plant-based nutrition program. This was called the GEICO study. So employees who had a BMI of greater than 25 and or type 2 diabetes were randomized to a low-fat vegan diet or no diet changes for 18 weeks. They were randomized into group settings rather than individuals. Intervention sites had weekly group support lunch classes that were held for an hour by a registered dietitian, a physician, and or a cooking instructor. And the control sites were not given any dietary guidance. They found that the intervention group lost an average of 6.4 pounds, had a decrease in their A1C of 0.7%, decrease in total cholesterol by 12.6 milligrams per deciliter, and decrease in LDL cholesterol by 11.1 milligrams per deciliter. So again, significant findings here with the diet intervention group. And then finally, these studies here. So this was a GI clinic in Japan. A plant-based diet was found to be effective in maintenance of remission in Crohn's disease by 100% and 90% in their 1 and 2 year follow-ups. The same group also reported a relapse rate of ulcerative colitis in a single group trial. Relapse rates at 1 and 5 years was 14 and 27% respectively. One of the limitations of this trial is that there is no control group. However, other groups have reported relapse rate of 5 years to be upwards of 58 or 75%. So showing that the diet intervention compared to other trials was proving, greater benefits. And what is really noteworthy here is that this particular plant-based diet consists of largely plant foods, but they were also allowed to consume a small amount of dairy-like yogurt, and fish was allowed once per week. And they could have 1 serving of meat every 2 weeks. So they were allowed kind of what we think of as a plant-based diet, largely plant-based, but some animal proteins here and there. So how does this translate over to enteral nutrition for patients and plant-based formulas? So we know now that we have this really large evidence of data for plant-based diets for the general population and for various disease states, but then how does this really translate over to the use of plant-based formulas? So just kind of going here, and I won't get into all of the details on this slide, it is a little bulky, but to show that, formulas really has been embedded in the milk industry because, milk has really been deeply ingrained in human civilization. So dating back as far as 8,000 BC, this is really when the first evidence of, cow's milk became about. And then even as far back as 4000 BC, there was early evidence of milking cattle in Britain and Northern Europe. Fast forward, right, the formula, world is really deeply ingrained in this dairy, product. And in the 1970s, that's when modern formula first became available, and again, dairy-based. And so really for about the last 50 years, these formulas have not changed. But as the research and emerging evidence is coming about with these plant-based diets, the enteral formula world has been a little bit slow to catch up, but really getting there in understanding the benefits of going plant-based with these products. Looking at plant-based milk, so one thing that we really want to make sure that we emphasize is that plant-based formulas are a lot different from plant-based milks. And so plant-based, milks are an alternative to cow's milk, can be great for patients with a cow's milk protein allergy, a lactose intolerance, or even just following, again, for health reasons. Oftentimes we're seeing things like soy milk, almond milk, coconut, rice, pea. There's all types of plant-based milks on the market. There's even some that combine sources of plant-based products to greater improve, some of the health ingredients in them. And what you'll see across the board here in this chart is that they vary pretty greatly in the amount of fat that they contain, protein, carbohydrates. And so when we're talking about kids who are, drinking plant-based milk, that is one of the things that you do need to be careful about. When you're looking at a plant-based formula, this is where it really differs because those formulas are, providing a consistent amount of fat, carbs, and protein, as well as the micronutrients that patients would need to grow. So not interchanging the two and understanding that each has their place in, a patient following a vegan or a vegetarian diet. And again, too, so you want to look at, the adequacy of a plant-based diet overall, right? So plant-based milks, plant-based formulas, and then just the diet in general. And so as dietitians, we want to make sure that our patients are consuming what they need. Is the protein source containing all of the essential amino acids? If proteins are not containing all of the essential amino acids, how do we supplement or combine sources to get all of those essential amino acids for our patients? What about vitamins and minerals? How do they, differ among various sources? What's the bioavailability from various sources? And how does this affect our patients? So, limiting nutrients in a traditional oral diet from the plant-based route can be supplemented with these plant-based formulas that are designed to be sole source nutrition. These are some of the most common plant-based protein sources that we see right now. So largely we know plant-based sources to be soy. That was really the first one to hit the market as a vegetarian protein source, followed by pea, rice. We also have legumes, peanuts and tree nuts, and hemp. So some, pros to following a plant-based diet and getting these plant-based protein sources are for patients with a milk protein allergy. Also, they are sustainably sourced. But again, one of the cons is that these sources may not be complete proteins. However, again, when you mix these together, you're going to get all of the essential amino acids that you need throughout the day that your body can use. Looking at protein quality. So how do you measure protein quality? I know this is something that we don't often use in clinical practice, but it's definitely coming to light more and more, especially because of the plant-based world. So when you look at protein quality, the gold standard for measuring by Food and Agriculture Organization and World Health Organization is the PDCAS, which is the Protein Digestibility Corrected Amino Acid Score. This ranges on a scale of 0 to 100, but is often truncated down to a 0 to 1.0. This is looking at the lowest indispensable amino acid ratio of the protein, and they multiply it by the fecal crude protein digestibility using a growing male rat model. That is one of the limitations. Any of these that are looking at protein quality are going to be using animal models because that's the safest way to be able to perform these studies. So again, as I mentioned, combining sources can not only increase the overall quality of the proteins, but it can actually help in a specific product if you have multiple plant-based sources to increase the PDCAS. It can pull from the different amino acids of each of the sources and thereby improve it. Digestibility of proteins in whole foods can be affected by things such as glucosinolates, phytates, tannins, and so you need to be careful of how digestible is this protein source, which actually plays into the PDCAS. There's also variation across labs as well too, but for the most part, we understand a general range. So you'll see here in this chart on the right-hand side, the PDCAS values of some of the commonly used plant-based proteins. Some of them have ranges because they've been studied based on the source, the growing conditions, the labs that they're using. So you'll see yellow pea has a range of 0.54 to 0.98 PDCAS. Rice is a 0.58 to 0.62. Interestingly, peanut butter, which we, talk about, patients maybe adding peanut butter as long as they're not allergic to their diet, actually only has a PDCAS of 0.45. So again, not that it's something that you don't want to recommend, but it's interesting when we think of peanut butter as being a good source of protein. When you look at a product that is 9 grams, that PDCAS means only about 4 grams of it may be digestible. So looking at the FDA guidelines for protein labeling as well too, and taking into consideration the PDCAS, the labeling must reflect PDCAS in specific cases. So if the food is meant for patients ages 4 and up and has a PDCAS of less than 20, meaning that most of the protein is not going to be bioavailable, you're going to want to know that. If the food is meant for ages 1 to 4 with a PDCAS of less than 40, so of course with our kiddos who need to grow and get the amino acids that they need, we again want to know what is the quality of this protein. So if they fall into either of these two categories, it would require labeling as either not a significant source of protein, or the label needs to reflect the actual percent daily value based on the PDCAS of the protein. So even if it has 20 grams of protein added, if only 5 grams of that is bioavailable, it needs to reflect the 5 grams as the percent daily value. If the food is meant for infants up to 12 months and has a protein efficiency ratio of less than 40% of the reference, which is casein, then it must contain the statement, not a significant source of protein. And the protein content then must be calculated using 6.25 times the nitrogen content of the food. So this definitely gets pretty granular and in-depth, but just things to be aware of as we may be recommending plant-based diets to our patients. If the food product also makes a claim, like on the label, it says, 15 grams of high quality protein, but it's plant-based, then the corrected percent daily value must be placed on the label. So anytime they make a claim about protein, they must reflect the percent daily value and bioavailability on the label. And then you'll see here the percent daily value for adults, pregnant and lactating women, infants, and ages 1 to 3 as well. So to give an example of this, right, with the protein claim, if you have product A, the label claim on the packaging has 20 grams of protein. So this is required to have the percent daily value reflect the PDCAS of the product, meaning how bioavailable and digestible it is. If the PDCAS is 0.8 or 80, and you're looking at an adult who needs that 50 grams as their total daily value, 80% of that 20 grams that's listed is 16 grams. 16 divided by 20 gives you the PDCAS, which then can get calculated into the percent daily value, which is 32%. So when you're looking at this, right, you're looking at it's got an 80% value. So what is the total value? You're only going to use the 16 grams that is bioavailable to calculate the percent daily value. If the PDCAS was 1 or 100%, then the percent daily value would actually be 40% from that same food product. You can also calculate it backwards. So if you don't know the PDCAS of a product, you can figure it out. So if the label claim again is that 20 grams of protein and the percent daily value states it's 28% of the daily value, again, looking at an adult as the reference range, 28% of that 50 grams that's recommended is 14 grams of bioavailable protein. 14 divided by the 20 that makes the claim on the package is a 70 or a 0.7 PDCAS. So you can either calculate it, in this order where you're looking at the percent daily value, or reverse calculate using percent daily value. Also want to look at gastrointestinal tolerance. So when we're talking about formulas, and plant-based diets in general, you want to look at the varying degrees of gastric emptying. So we know that formulas are largely dairy-based, consist of casein and whey. So casein is a slow digestibility protein and whey is pretty fast digesting. So what that means is that casein tends to really clump up in the stomach. It can cause a lot of discomfort and really is slow to digest, and all of the amino acids may not be utilized well. Whey, on the other hand, is very quickly digesting. It doesn't form curds, but its transit time does allow for amino acids to be utilized really well. Then you look at plant-based proteins, and in particular, we have here soy, pea, and rice. They're an intermediate digesting, and what that means is they actually fall right in between whey and casein, and that they may form small amounts of curds in the stomach upon digestion, which can help patients to feel a little bit full. They feel satiety, but they're not just sitting there. They then actually digest pretty quickly and still allow for the body to utilize the amino acids that they need. So it's actually a nice benefit here because it gives the best of both worlds and may actually help to improve tolerance to some of these protein sources. Relating this to studies and looking at a couple of studies, so we're going to go through here now some plant-based formulas and plant-based proteins and how they relate to certain disease states. So in the first study, this is patient-reported outcomes indicate plant-based enteral formula improves nutrition and GI symptoms. This was 392 surveys that were filled out by actual users of a plant-based formula. 63% of users reported that the plant-based formula improved digestive symptoms, so easier bowel movements, less reflux and abdominal discomfort, less bloating or nausea. And 79% reported the plant-based formula improved their nutrition, so they felt better overall and they were able to meet their needs more frequently. In the second study, this is improved GI tolerance and weight gain in pediatric patients using plant-based enteral formulas. In this, 86% of patients had improved weight for age Z-score on a plant-based formula, and 90% of parents reported better tolerance on plant-based formula compared to their child's previous formula, which was largely dairy-based. This is the plant-based protein effect on glycemic control. So when you partly replace meat protein with soy protein, they wanted to look at insulin resistance and blood lipids in postmenopausal women with abdominal obesity. So in this randomized crossover trial, it was demonstrated that partial replacement of meat with soy products totaling 30 grams per day of soy protein increased insulin sensitivity. The diets were isocaloric and they contained the same amount of monounsaturated fatty acids and polyunsaturated fatty acids, as well as saturated fatty acids. Total cholesterol decreased more in the soy group compared to the control, and LDL cholesterol decreased more in the soy group compared to the control. There is limited research available regarding plant protein isolates or supplements and glycemic control at this time, but this is interesting and would, really warrant further research in this area. Next up, we have plant-based proteins and their effect on lean body mass. So both of these studies were pretty similar, and they looked at pea protein compared to whey protein. One had a placebo in their study and one did not. However, both studies showed that there was no difference between the whey and pea protein groups after completing the same exercise programs and ingesting the same amounts of whey and pea protein. And they also saw significant gains compared to the placebo group in this one trial. So this is basically demonstrating that whey protein and pea protein can have similar effects on lean body mass. And then finally, for oncology research, so the first study looked at the efficacy of a cereal-based oral nutrition supplement on nutrition status, inflammatory cytokine secretion, and quality of life in cancer patients who were undergoing therapy. The oral nutrition supplement contained oat and soy protein along with chia seed oil, fermentable fiber, vegetable, and grain powders. The oral nutrition supplement group had decreased levels of interleukin-6, interleukin-1b, and improvements in emotional functioning and fatigue at 4 weeks. They also reported decreased symptoms of nausea and vomiting. And then finally, for the research, we have a plant-based peptide enteral nutrition with phytonutrients in a pediatric patient who was status post bone marrow transplant. This was just a single case report. This patient had improved GI symptoms after transitioning from a dairy-based product, also had weight gain and no documentation of phytonutrient interactions with medications. So just a couple of studies here demonstrating the use of either plant-based proteins or plant-based formulas in various disease states. So to really wrap up, these are the benefits of plant-based proteins. So again, for patient preferences or food allergies or intolerances, plant-based proteins are free from dairy, may or may not contain soy. They may be better tolerated compared to whey or casein. They provide phytonutrients and fiber, and they are also eco-friendly, sustainable, and provide cost savings. So in conclusion, the health and economic benefits of plant-based diets are robust and strong. There's a lot of emerging evidence of plant-based proteins and formulas with positive results. Plant-based proteins can have 100% bioavailability and a PDCAS of 1.0, either on their own or with supplemental amino acids or combination of sources. Preliminary evidence shows plant-based formulas and supplements to be as effective in muscle accretion as their animal-based counterparts, and tolerability of plant-based proteins and formulas is really promising. So these are my references for today. Thank you all for joining, and now I would love to open it up for any questions that you might have.
Thank you, Melissa. This is a really informative presentation. We do have a few questions. The first one is, for the plant-based diet, are the patient being exposed to too much fiber side effect? If so, how can we reduce this risk?
So yes, so with plant-based diets, with anything, you always want to try to ease into it. You wouldn't want to go completely from, one aspect of patient having, a diet that's low in fiber and really high in animal products to a completely plant-based diet. So from that perspective, I would always recommend slowly transitioning, also increasing fluid intake to account for increase in fiber. However, in looking at the data overall, if you're asking about once somebody is on a plant-based diet, could they ever have too much fiber? There's actually no evidence to show that there will ever be such a thing as too much. Of course, it would really just affect how we tolerate it and how we feel, GI-wise. But most of the time you can get adequate amounts of fiber on a plant-based diet and not overdo it. So transition slowly and then always adjust as needed on a per patient basis.
Thank you. So the next question is, have you determined the protein quality of the K-Farm product?
Yes. So we have a 1.0. We do have pea protein and added amino acids to improve that PDCAS up to a 1.0 and be equivalent with any animal or dairy-based products.
Okay, so from your earlier slide, what is the reason for the large range in the quality of the pea protein based on the source?
That's great. Yes. So it has to do with growing conditions. So just as we know that micronutrients can vary based on soil conditions, temperatures, where it's being grown, same thing as that, there too. So also how is the protein, being extracted? Our growing conditions can affect quality. And so that's, one of the things where you either always want to be using the same source and knowing, who your crop is coming from and what protocols they're following. So that's how you can make sure that you are getting either, that higher PDCAS that you want from that product. But really it goes back to that, the crop growing and the nutrients in the soil.
Okay, thank you. And then another question is that I have a few patients complain of abdominal discomfort with the K-Farm 1.5. Have you seen this? If this is one of the reasons why. Is this one of the reasons why the 1.4 came out?
So actually, what I will say to that is oftentimes we find that when patients go from a formula that maybe didn't contain a lot of fiber to one of ours that do contain fiber, again, there might be a transition period that is needed for that particular patient. So if there's any concerns about that, I always recommend you can call directly into Kate Farms and we can talk you through that. Actually, we brought out the standard 1.4 to have a higher calorie intact protein plant-based product. So the 1.5 is a peptide-based product, and we had our standard 1.0, which is a little bit less calorically dense. So we wanted a standard product that had more calories and more protein in that intact protein space.
Thank you. And then I have another question is that, do consumer inquire if the product is organic?
Yes, so our products, this is a good question. So actually, as of right now, we have pursued USDA organic for all of our products. So we are in a transition phase. What that means is that prior to, all of our products were certified organic with about a 93% organic ingredient range. We decided to pursue USDA organic. These products are actually moving into the market as we speak and will transition through the remainder of 2020. We will have that USDA organic seal on the front of the carton. That is how you'll know that you have the USDA product. And that means that we've now achieved greater than 95% organic ingredients in our products.
Okay, thank you. We're way ahead of schedule. So if any of you, one of you have questions, feel free to type it in. All right, so I had another question. Will the organic seal increase the cost?
So it depends on the product. It will not, the only patients that it would affect are patients who are paying out of pocket cash pay. We are working with DME companies in order to work with pricing for those cash pay patients. Otherwise, for any patients with insurance coverage who cover Kate Farms, that would be taken care of and no additional costs to those patients. So yes, slightly, but we also know that we wanted to get that higher, quality USDA product out.
Okay, have another question came in. How would you compare your peptide formula for adult to standard peptide formulas?
Yes, great question. So, when you look at the protein, pea protein versus say a dairy-based protein that has been hydrolyzed, the peptide chain lengths are very similar. So the amounts of di and tripeptides are very similar to that. So in addition to that, interestingly, besides being plant-based and a vegan product, one of the things that we do see is, as I mentioned, because pea protein has a nice moderate transit time through the GI tract, that may help patients to tolerate it better. And we have found patients tolerate the standard product of our product before needing to go to any sort of peptide. So that's another thing to always consider with the plant-based products is there could be the ability to go to a standard before a peptide. Otherwise, our peptides, are similar in that peptide chain length to the dairy-based proteins. I hope that answers the question.
Okay, well, thank you. And then I have two more questions so far. So how many patients that you know that obtains K-Farm product without insurance?
That's a great question. I would actually have to talk to our access reimbursement provider and get that information for you. So we are largely covered. Yeah, we're largely covered under the most common insurance codes. So if you're covered for other traditional products, either in like a B4150 or a B4161 category, we fall in those standard and peptide insurance codes. So oftentimes there's no additional documentation just for the Kate Farms product. If patients have coverage, they will be covered. So I can, get that further information, but we do have really great eligibility for insurance coverage overall.
Thank you. Yeah, when you get the answer over to us, I can certainly send it out to all the attendees.
Okay, great. I'll let you know, Vivian. Thank you.
And then for now, do you know which insurance company that actually covered the K-Farm products?
For Georgia specifically?
Yes. Sure.
So we have a wide range of private insurance companies that will cover us. I don't know about the state mandated ones, but I can again check with Ava, the territory manager, and have her get that information over to you.
And then I think it's along the same line. Is there a patient assistance program for K-Farm products?
So we have a really great customer care team, and I always recommend that you utilize that. It's where you can call in, talk about the usage of the product, insurance coverage. So if there's any issues with insurance coverage, our customer care team is really great at filling the gaps, finding any loopholes, and talking through that. In addition to that, they also will connect any healthcare providers or patients directly with one of us, the dietitians, for any clinical questions that you might have. And then we also do have some discount codes for patients that have to pay out of pocket who aren't covered by insurance that we can offer as well too. So that would definitely be Ava, the territory manager, is your resource. So I'll have her follow up with all that great detail as well.
Okay, thank you.
Mm-hmm.
Is there any more last minute questions? All right. Well, thank you, Melissa, again.
Absolutely.
Oh, I guess we just have one more just jumped in. Okay. So does K-Farm has packaging for closed system, like a 1 liter bag?
So at this time, no, we do not. However, we know that this is a big ask of clinicians, especially in the adult inpatient space. So it is something that we are looking into.
All right, so I actually just got the comment from Ava Cooper that from K-Farm, where she mentioned that you guys are widely covered by insurance here in Georgia. She always recommend going through and the DME or infusion company to have them run the benefit. And if someone want to discuss further, they can certainly reach out to Ava. And then we have one question, just another question. Does the K-Farm product contains iron?
Yes. So we use a source of iron. We use ferric orthophosphate. We also actually just recently were transitioning to that new source of iron in order to improve bioavailability. So we know that one of the concerns with plant-based diets is iron and iron absorption. We take that into consideration, and with all of our micronutrients, we look at DRIs, bioavailability, how well it might be, absorbed, and we take that into consideration when formulating the product.
Okay, thank you. Any other last minute questions? We'll give it another minute or so. All right, let's see. One come in. Okay, so have there been any study on the follow-up iron indices on patients that on those formulas?
None at this time, but we do work closely with our clinicians, and so it's one of the great things about our company is, we as the dietitians in the company will partner with a lot of clinicians. We ask them, for all feedback, anything, even adverse symptoms that we see. And, right now we don't have any reports of any adverse effects with iron absorption in certain patient populations. But as we grow as a company, research is very important to us. And we do have a lot of abstracts on our product and continue to research in various areas. So that is something we can look into having as a formal, research write-up.
So this kind of like a follow-up question is as well. So is there any risk of in terms of the interaction in the phytate and also the iron in the K-Farm products?
Yeah, so that's a great question. Again, we actually look at the bioavailability of the iron source, the potential of phytates, fiber, anything that could potentially look at absorption of iron. When you look at the general diet and they calculate the DRIs for the general diet, they also take into consideration that most iron from the diet is only absorbed at about 18%. So again, we know that that's very low. We know iron is tricky. And so we do formulate slightly higher to account for decreased absorption or bioavailability of the iron source.
All right. Well, thank you. If anyone have any more questions, you feel free to send it to us at gaspinga@gmail.com, and we can certainly share that with our speakers. And like I said, we're way ahead of schedule, so which is good. And thank you, Melissa, and